realize that it was an addiction. She became educated. Once she realized that it was an addiction, it had to be treated as such. And what is the best way to overcome an addiction? Yeah, it is total abstinence for life. And then you have to give up the things that are associated with the addiction. So we asked her to make a decision to give up. What do you think she had to give up? Her razor blades. And of course, this was a big crutch for her. And I remember it was quite a time. It was our clinical psychologist that was talking to her, and with trembling hands, she handed that razor blade over. And in the middle of the program, since nutrition is a major part of our program, we teach them how to shop at a regular grocery store. And in the middle of that program, a few days after she had given up her razor blades, guess what she bought without us knowing it? Razor blades. You know, addictions have that way, you know, where like the dog returning to his vomit, so to speak. Fortunately, her husband was a companion with her, so he reported what had happened. And so we had another conversation with her. And with trembling hands, she gave up her razor blade again. But at the end of the program, by the end of the program, actually from that point forward, that program was ran 10 years ago. She has never cut since. And so when we take care of the mental health issues that's causing it, there's not a need for those type of things that come up. But actually, I know that's a long answer to saying self-mutilation as part of morbid thoughts, actually doesn't qualify. So what else would be an example of a morbid thought? Not necessarily fear. Fantasizing about someone else dying would be a morbid thought. And many individuals actually believe their depression is caused by someone else. And often it's someone else that they don't know how to necessarily separate from. It might even be their spouse. It might be their mother. It might be, who knows who. But part of their morbid thoughts is fantasizing about someone else's death. But that's not the most common morbid thought. The actual definition of morbid thought is preoccupation with death or symbols of death. And so you are seeing when people resonate with symbols of death. My wife showed me the other day of a bathing suit line, and the bathing suit line had nothing but skeletons and skulls all over the bathing suits. What is the fashion industry doing? They're capitalizing on the increased frequency of morbid thoughts of people, and when someone wants to buy that and likes it, resonates with it, it's a clear sign of a morbid thought. People are tattooing symbols of death on themselves. They're doing all sorts of things in regards to that. My son, last winter, or the winter before last, it was his birthday. I was going to buy him a snowboard. In the wintertime, we like to go snowboarding and skiing. And he found the right snowboard, and he turned it over, and he says, "Dad, I don't want it." I said, "Why is that?" And he turned it over for me again to look, and there was nothing but a skeleton on the back of that snowboard. And I asked the clerk, I said, "So why is this here?" And the clerk says, "Well, this was designed by a famous snowboarder by the name of," it's not the most famous snowboarder because I would have heard of him, but it was some snowboarder I hadn't heard of. And my own thought when I was realizing that that's how he designed it is, I wonder how many other symptoms of depression that individual has. By the way, speaking of extreme sports, many people actually, instead of seeking a wise, comprehensive program for overcoming depression, many people with severe treatment-resistant depression actually go in to extreme sports thinking that if I die in the process, it's going to be no big deal. And if I don't die, my adrenaline rush will be so high that maybe I'll get over my depression. And of course, that's a dangerous situation to be in, and many of those people actually do lose their life in the process. The ninth symptom of depression is fatigue. This is where it's not the interest part. This is where you run out of energy. And so you just don't have the energy at the end of the day, or maybe you don't even have energy at the beginning of the day. So you don't need all 9 of those symptoms. How many do you need? 5 out of 9, and you have major depression. And if you have 2 out of 9, it's still abnormal. That's called minor depression or subsyndromal depression. And so it's thought to be in the variant of normal to have one of those 9, but 2 of those 9 is still significant. It means you're on your way to major depression, and 5 out of those 9 is major depression. Now, depression would be bad enough if it just did those things, but unfortunately it does a lot more than that. It increases the risk of stroke by 50%. It increases the risk of sudden cardiac death in those who've survived a heart attack by 2.5 times. How well you do after a heart attack has more to do with your mental health than even what heart medicines you're taking. It increases the risk of heart disease in men. It increases the risk of death from cancer in both genders. It increases the risk of death from pneumonia, which is still in the top 10 causes of death here in South Africa. And it also increases the risk of suicide. Now, many people are aware of the association between depression and suicide, but they're not aware of some of the particulars that are involved. Suicide is often an impulsive act. So you have depression, you have feelings of hopelessness, and then something happens where you become more impulsive, and then you do it, or at least attempt to do it. And to illustrate this, one of the ways in which people in San Francisco, one of the most famous ways to commit suicide in San Francisco, California, do any of you know in South Africa how they do it? They jump off the Golden Gate Bridge. You know, it's 400 feet above the water, and it's kind of like hitting concrete when you jump, and there's only a 4-foot fence there, and there's a big highway, you know, lots of cars on either side, and then they have a little place in case you have car trouble to be able to pull over, and so people will pull over and then quickly make that jump. There have actually been 20 people who survived that jump. They actually landed just right, by luck, really, so that they did not die. Now, they ended up going into the intensive care unit. They ended up with broken bones, sometimes lost limbs. The most common problem was that they shrunk by several inches because they had collapsed broken vertebrae. Most of them that landed happened to land on their feet. And so their life significantly worsened as a result of this decision to jump. So an astute psychologist decided to do a study on these 20 people who'd survived the jump. And the first question he asked is, do you wish you would have been successful in committing suicide? What do you think they said? They said no. We are glad that we were not successful. So just to make sure, he asked them a follow-up question. He said, so you realize then you made a mistake by jumping? And they said, big mistake. Yes, we realized we made a mistake. Then his third question was simply this: when did you first realize that you had made a mistake? 2/3 of them said, as soon as my feet had left the bridge. So they're on their way down and they're thinking, uh-oh, this may not have been a good idea. And it illustrates often the impulsivity of the act. Of course, for over 99% of them, it was too late at that point. They were probably having the same feelings, but it was too late at that point. And this is one of the enigma of the pharmaceutical industry, because the pharmaceutical industry makes it very clear that when you put a depressed person on an antidepressant, their impulsivity goes up before their depression gets better. And that's why they all have these big black box warnings. And that is, if you put this patient on this drug, it might tip them over the edge and they might commit suicide. So that makes it pretty difficult. You're wanting to help the person with depression, and so the doctor often just has medicines in their toolbox. And so you give them a medicine that actually increases their likelihood of suicide before the depression gets better. Another problem with the antidepressants is not only do they worsen impulsivity, but they eventually cause an I don't care attitude when the depression does improve. So studies show that if you have depression and you're taking an antidepressant, you're actually more likely to miss work. Why is that? Because if you're not feeling that great, you say, who cares? I don't care. You know, my boss can just handle it some way or another. I'm just not showing up. And then although it can help their depression, they'll find out that even when a loving person dies in their family, they don't feel sad about it. They don't have the ability to cry at the funeral often. And of course, both of those symptoms are very common in those that take antidepressants, and one of the reasons why we need to find better ways of treating the illness. In fact, it's very clear, the pharmaceutical industry is finally owning up to this, that medications have their limitations. They only help people significantly about 20% of the time. Now, up to 70% of the time, the pharmaceutical industry will state that it produces some improvement, but they admit that 30% don't improve even the slightest. But out of the 70% that improve, placebo will improve about that many. And so it's not too much different than taking placebo, except for about 20% of the population that seems to do very well. Another problem with medicine is they've only studied them out short term. And we know it doesn't work within the first week or two. That's why they're always doing studies month, 2 months, 3 months. It's been thought that depression is something that takes months to improve. Actually, prior to our research, which I'll be telling you a little bit about, I used to believe that as well. In fact, when we first began to run depression recovery programs, I told everybody there, do not expect to get better within even 3 weeks. We're putting you on this program so that you can continue on this program in your home setting, but remember, it's a 20-week program, and don't gauge yourself until you're 8 or 12 weeks out. That's how long it's going to take. And I was very surprised when I saw everybody getting better within 19 days, and then we started studying it, and everybody was getting better within 10 days. So when you treat it in a comprehensive manner, it won't get better the next day, but it will get better normally starting within a week, and by 10 days it can ramp up pretty significantly. But back to the medicine studies. Studies are showing that if you put a person on placebo or you put them on medicine, the medicine will do better than placebo for the first 3 months, 4 months, 6 months. But then there will be a crossover after 6 months. And by 1 year, the placebo individual is doing significantly better than the one taking the medicine. Dr. Whitaker has studied this out. This has just been research in the last few years where they're looking at the long-term data on antidepressants. And Dr. Whitaker, along with other psychiatrists and ones studying this out, are stating that antidepressants really should only be used short-term, because if you utilize them long-term, they will end up causing more of the problem that they were designed to treat. Because of some of the changes that take place. So once again, one of the reasons why we need to find ways besides these medicines in treating the disease. Now, of course, depression can cause all those deadly side effects, but it can also cause things that will just decrease your quality of life. Headaches are very common in those with depression. In fact, we have many people on narcotics, all sorts of shots for their migraine headaches and other types of headaches. And within 10 days, they won't need another pain medicine for their headaches. If we take care of their mental health issues, often the headaches completely clear up. Osteoporosis, you lose 2 to 4% more bone mineral density per year as a result of depression. When combined with stress, it increases the risk of HIV progressing to AIDS. Not everyone, as you know, with HIV will get AIDS, but if you have a mental health problem, you're much more likely to do it because of suppression of the immune system that helps bring it about. It increases the risk of return to addictive behavior such as drinking. Now, why is that the case? Why do people with depression have an increased risk of going back to an addiction or going to an addiction? It's a form of self-medicating again. They're trying to feel better for the short term, and they're feeling so bad, they say, I just want to feel better, even for a few hours. And so they go back to a previous addiction. And of course, does that help their situation? No, it actually complicates it much more. It becomes even a more severe problem. It increases problems with anger or hostility. So everyone with depression ends up having social complications from their disease. And that means that their marriage is being affected, the raising of their kids is being affected as well. It increases the risk of developing asthma. And so even lung problems can result. It increases the chance that your offspring will suffer depression and physical medical problems. So it not only hurts the individual, it hurts the chances for the offspring as well. And of course, one of the most gratifying things is when we take young mothers into our program, because when they get better, everybody gets better in their family, and they end up turning their family's course in a very positive direction as a result of coming. It increases the rate of decline in physical abilities with age. Whether you end up in a nursing home or not has much more to do with your mental health as you age than your physical health. It increases stress hormones. That means cortisol levels go up. And of course, that produces some adverse effects on the brain. It decreases sex hormones. That may or may not be a good thing, depending upon the individual and their situation. But studies show reproductivity does go down with depression. It suppresses the immune system in ways that are mentioned there on the screen, and it also decreases the memory. In fact, rather significantly, the stronger the bouts of depression, the longer those bouts, the more the memory is adversely affected. And that's something that we actually measured in our last program. We're starting to do more studies. We measure a lot of different things, but in this last program, we gave them an extensive memory test when they came in and an extensive memory test when they left 10 days later. There was a different memory test, so it wasn't any of the same things that they had to remember at all. And significant improvement occurred in the entire group, and so they were very gratified to see their memories starting to come back. Of course, that produces some positive consequences as well. And then the cost of depression. Although this has been in the United States, you can kind of translate this over. I notice right now it's about 10 Rand per dollar, so you could just multiply this by 10 in South Africa on the dollar amounts. But an average person who works with depression will lose 5.6 hours on average of productive work per week. 80% of people with depression are impaired in their daily functioning. They have less ability to concentrate, lower efficiency, less ability to organize their work. They're over twice as likely to take sick days. And as mentioned, the costs of absenteeism are actually more related to taking antidepressant medicine. But in general, you will still be twice as likely to take sick days. And depressed people are 7 times more likely to become unemployed. When there's an economic downturn, the boss will know who is the least productive, and he'll try to cherry pick the least productive workers to lay off at that point. And of course, many of those cases will actually be mental health cases, those that have been functioning with depression. The long-term effects of psychological problems have been studied during childhood. Children were followed for 40 years to determine the effects of illness and psychological problems on their life chances. 7 fewer weeks of work per year, a loss of 35% in lifetime income, and a lifetime loss for each family who has a depressed family member of $300,000. This is significant when you take a look at the lifetime effects of this. The personal loss in that individual is $10,400 per year in income by age 50. And often they don't realize this. They have economic issues. In fact, most of the people that come to our depression program don't have the money to come. So how are they coming? Well, they're coming because others have heard about their program and believe enough in them that they've been able to raise money for this individual. We had one girl that came to our program. I mean, talk about a basket case wreck in anxiety and depression and all sorts of family relationships. She had just separated from a husband who was beating on her and all sorts of issues. She was strung out on Xanax and clonazepam and all these benzos, plus a lot of antidepressant medicines. But the person who believed in her was actually her doctor in Georgia. And her doctor paid for her entire way to come to our depression recovery program. And fortunately, I was able to return him to her. By the way, she was also on narcotics for all sorts of pain medicine, but within 10 days, she was off all of her benzos. She was off her narcotics. Her depression scores no longer existed. And so she didn't have depression or anxiety. And what a dramatic turnaround. She was just absolutely thrilled. She's felt better than she's felt her entire life. And of course, there's still a program that she's going to have to follow in her home setting. But it's often people that have noticed, and of course this doctor has noticed the difference in other people. So when someone else sees someone go through the program and see that type of transformation occurring, then you can see why it's easier to raise money for these individuals to come. But many of these people don't want to be there because they don't think this program is going to help them. Many people with severe depression have been so many places, they think there's no program on the planet that's going to work for them. But someone else does enough to pay their way. But notice, even though the program, I'll just tell you, in the U.S., the program costs $6,000 for 10 days. And of course, it's actually dirt cheap when you consider all the things the individual gets from this, because they're getting well over $1,000 worth of laboratory. They're getting a lot of clinical psychology visits, spiritual psychology visits, all of their hotel stay, their food, the entire hydrotherapy treatment programs, and other types of treatments, the music therapy. All of this is included in this price. And insurances are starting to reimburse for it because they recognize the data that it works. So often they get some reimbursement from insurance. But nonetheless, $6,000, compare that with $10,400 less income per year. And so these individuals all get their $6,000 back, maybe not from an insurance check, but now they're leaving, since they're depression-free and anxiety-free in most cases, and their income or their emotional intelligence is now at the top 25 percentile, they become very desired employees. And I'll tell you that some of those employees that were basket cases in depression, I have hired myself, and they are exceptional employees after this. And so I've always been willing to invest in people who have gone through this program and had success, and they can often make me even more successful by filling a spot that is open in our office or in other ways. But anyways, in this study, the cost for the total group over one's lifetime, $2.1 trillion, which does not include the increased cost of medical care that all of us must assume. It turns out, if you just look at this economic data, and there's a lot of reasons for national debts. But in America, of course, there's a lot of talk on how we spend too much money. We need to tighten the belt. We need to get expenses under control and those sorts of things. It turns out that if depression and anxiety were eliminated from the United States, there would be no debt whatsoever. You say, why is that the case? Think of all of these individuals making $10,400 more per year and less costs on the Medicare and insurance companies and all of the government-sponsored health programs. And that extra $10,400 will result in more tax revenue coming into the government. We wouldn't have to cut expenses at all. We would just have to take care of the mental health issues, and there would be no more debt in our country, despite the fact that we do have holes in certain areas. And so that's something to keep in mind. A lot of times the burden of any country is related to the mental health problems in that country. And if we're able to make a difference in that, we can actually have all ships rise, so to speak, and the entire economy do far better. Years ago, Ellen White was criticized for writing this. This comes from the book Ministry of Healing. There's a chapter there, a great chapter called Mind Cure. But she said this: the condition of the mind affects the health to a far greater degree than many realize. Many of the diseases from which men suffer are the result of what? Mental depression, grief, anxiety, discontent, remorse, guilt, distrust, all tend to break down the life forces and to invite decay and death. She's no longer being criticized for writing those statements because it's been clearly demonstrated that everything that she wrote is actually true there and, of course, other places in regards to mental health. Well, you might wonder how I myself, I just need to let it be known, I think it's been said multiple times in introductions, but I myself am not a psychiatrist. I'm an internal medicine physician, so you might wonder how in the world, internal medicine is, an internal medicine physician is someone who treats internal organ diseases in adults. And we're often the one called in when there's a lot going wrong with the patient. So we do a lot of critical care work, and we try to referee some of the specialists in critical care. The cardiologists will want to dry out the lungs and give a lot of diuretics to someone in bad heart disease, and the kidney doctor will come around and saying, hey, you're getting rid of the kidney function here, we need more fluid. And so they'll try to pour in more fluid, and so the internist is often the referee saying, wait a minute, no, let's take all these organs into perspective and let's run the fine line here and see exactly where things are at. So that's the type of training that I received. And of course, internal medicine physicians also are trained in regards to diagnosis and difficult diagnoses. So I'll just mention that after my residency, I actually taught in an internal medicine residency for a while. And I used to teach my internal medicine residents to learn the common diseases well. I wanted them to know congestive heart failure as good as a cardiologist. Why did I want them to know it that well? Anyone? It's a common problem. They're going to see it just about every day of their lives. If you're going to see something common and you see it every day, you better know it as much as the biggest expert in the nation knows it. And so they would cringe when I would tell them, that's a lot of information. Really, I need to know it that well? Yes, absolutely, you need to know it that well. And furthermore, I want you to know pneumonia as good as a pulmonologist. Why is that? You're going to see pneumonias very frequently. It's a very frequent reason for admission. I told them I wanted to have them learn gastroesophageal reflux disease as good as a gastroenterologist. 50% of the population is going to suffer from gastroesophageal reflux disease. They're going to be in an internal medicine doctor's office. They need to know it that well. And of course, my residents later on, they would all thank me for that. They would have to learn it that well, and then afterwards they were very well thought of by their patients as well as the specialists. Because some of those patients would end up in specialist offices, and the specialists would look at what this internal medicine doctor did, and they'd say, he covered the gamut. I have nothing else to offer you. And of course, the patient would be gratified that they have that good a physician. Now, I didn't want them to know Guillain-Barré syndrome as good as a neurologist. Why is that? They might see it once in their life, and when they see it, they'll know it's something vastly wrong, and they'll be able to refer that over. But the common diseases I wanted them to know well. So after I finished teaching in my residency, my first year in a regular private practice that I started up in Oklahoma, the Nedley Clinic, there was an article that crossed my desk from the American Medical Association, JAMA Internal Medicine it's called now. It was called Archives of Internal Medicine back then. That showed up to 1 in 3 people who see an internal medicine physician as suffering from major depression. And I thought, common disease, do I know this as good as a psychiatrist? And I had to admit I didn't. And I also have to admit this. I didn't want to know it as good as a psychiatrist. Human nature. Why did I want to know it as good as a psychiatrist? You know, depression is kind of out of the realms of internal organs maybe, and you know, I love all the critical care work, but I don't necessarily want to get myself involved in that. But then I thought, you know what, I can't let my human nature give the sway here. What I can do, however, is to do a screening test in everyone who sees me in my office to see how many of them have depression. Because in Ardmore, Oklahoma, we're in the Sun Belt of the United States. I thought, you know, it can't be that high here. So I actually did the screening test, and we found out it wasn't 1 out of 3. It was between 1 out of 4 and 1 out of 5. But is that still common? Still very common. In other words, I was seeing it quite a bit. And so what I did is I sat at the feet of preeminent psychiatrists to learn about it. And I learned better how to diagnose it. I learned more about how to use high doses of medicines for it. Psychiatrists are experts at using combinations of high doses of psychiatric drugs to produce effects and side effects and those sorts of things, and to differentiate it from other mental illnesses. And so I learned quite a bit. Of course, I had to go through a lot of that in medical school, so some of it was review, but I was able to fine-tune the aspects of the traditional treatment of depression. But I recognized what was happening in these psychiatrists' offices was something that did not happen in an internal medicine office. These people were diagnosed with depression and anxiety, and they were being sent out the door right away with a prescription. And for an example, internal medicine people deal with swollen feet. And I thought, this is like seeing a patient with swollen feet, diagnosing swollen foot syndrome, and sending them out the door immediately with a diuretic medicine. Now, will a diuretic medicine, something to get rid of fluid, will it help swollen feet? Maybe or maybe not, depending on the